So based on everything that you've heard, very compelling evidence, then it begs the question, as Dr. Pantrath has just discussed, the role of the baroreflex in heart failure patients. The question is, could electrical stimulation of carotid baroreceptors upregulate the baroreflex, rebalance the autonomic nervous system, and improve heart failure symptoms? Next. So this is an important study. This was a proof of concept evaluation. Small study, but obviously very telling. So this was a study of 11 patients, single center. All the patients were on GDMT, New York Heart Association Class 3, an LV ejection fraction less than 40%. And Barostim therapy was delivered for 6 months. And you can appreciate here that you can actually see that this chronic stimulation of carotid baroreceptors in heart failure patients on GDMT did improve baroreflex sensitivity, or another way of thinking about it is it upregulated the baroreflex. Next. So back to the slide that you saw from Dr. Pantrath, you can appreciate, these are the targets that we're trying to pursue. We understand the backdrop in heart failure. So what is Barostim doing for us? And we've just demonstrated in the prior slide that there's an improvement in the baroreflex regulation. So now let's look at the effects on sympathetic tone. Next. So in the same study, so N of 11, they were able to document that chronic stimulation of the carotid baroreceptors in heart failure patients with background GDMT also reduced sympathetic tone steadily over the course of 6 months. You can appreciate here on the slide, pretty much everyone had a continuously downward slope in that tone, a couple of patients with some upticks, but overall, a very telling slide. And you can appreciate that the overall sense of this is that there absolutely is a down regulation over time. Next. So now we've seen that stimulation of these carotid baroreceptors also decreases sympathetic tone in heart failure patients on GDMT. So you can see we're starting to tick these boxes under our Barostim column. Next. We also know that there's additional preclinical and early clinical work that's demonstrated additional physiologic effects. We're not going to necessarily dive into that today in any great detail, but these preclinical data and early clinical work have been the foundation for a randomized clinical trial, which was BEAT-HF. Next. So I'm sure many of you are familiar with this study, and this was a prospective multi-center randomized trial. And the study was deliberately and intentionally designed to have 2 phases. So 6-month symptomatic outcomes evaluation, and then a post-market phase for morbidity and mortality. Patients were randomized in a 1-to-1 fashion, either to receive Baroreflex Activation Therapy plus optimal medical management, or optimal medical management alone. And patients were followed for 6 months for the 3 primary efficacy endpoints of a 6-minute walk, a quality of life assessment, an NT-proBNP, and then obviously underlying safety data, which is always important. The BEAT-HF study does have cardiovascular mortality and heart failure hospitalization endpoints built into the study, so that's an important component. And those patients continue to be followed longitudinally. The morbidity and mortality data will be completed in late 2022 and presented and published in 2023. But the results of the primary efficacy endpoints around symptomatic improvement ultimately led to FDA approval in August of 2019. It was important enough for the FDA to make this device available based on symptom relief to approve the device even before the morbidity and mortality data have been presented. Next. And here are some of the key inclusion-exclusion criteria for BEAT-HF, and obviously we would encourage you to read the paper when you have more time to digest it, but we think it's an important study, obviously. As you can appreciate, class 3 LVF less than or equal to 35%, a 6-minute walk, 150 to 400 meters, elevated NT-proBNP or previous heart failure hospitalization, stable, optimal medical therapy for greater than or equal to a month. CRT eligible subjects were excluded intentionally, as you saw in some of the prior slides. And there was no restriction, importantly, on AF or QRS with or concomitant device therapy, which is important, obviously, in our clinics. Next. Importantly, you can appreciate that if you look at this slide and a little bit of background information, so that darker color, dark blue, is the device group, okay? And then the light blue would be the control group, so that background therapy. And purple is the difference between those groups. And patients randomized to Barostim in addition to GDMT increased their 6-minute walk distance by 49 meters from baseline. There was a 60-meter difference in improvement compared to patients on optimal drug therapy alone. And you can appreciate at the bottom of this slide that this is about twice the improvement that's seen in some of the landmark CRT studies in the early 2000s. And that's on top of improvements in GDMT in the last 20 years. In multiple drug trials, 25-meter improvement has been considered, as you all know, clinically meaningful. And so the results in BDHF were more than double that. So very important findings, to say the least. We also know that Barostim, when we look at quality of life, for example, these patients undergoing Barostim therapy increased their scores by 21 points from baseline, which is a 14-point difference in improvement compared to patients on optimal drug therapy alone. And just to kind of put some contextual understanding to that, this is nearly 3 times the 5-point improvement that has been shown to be clinically meaningful to heart failure patients. And then you can appreciate here when we look at New York Heart Association, once again, obviously, we see some dramatic improvement here. So Barostim and GDMT had improved New York Heart Association class by 6 months, 52% improved by 1 class, and 13% improved 2 New York Heart Association classes. It's a 34% difference compared to patients on optimal drug therapy alone. So once again, to contextualize this, CRT trials noted about 20–30% of patients improved New York Heart Association scores at 6 months. Next. And then our NT-proBNP data was confirmatory and obviously built in to give us some more information to confirm the effect of the therapy, in addition, obviously, to symptomatic improvement. In BDHF study, patients receiving Barostim had a 21% relative reduction in their NT-proBNP levels at 6 months compared to baseline. That was a 25% relative reduction compared to patients receiving GDMT alone. And just to provide a little bit of backdrop and paradigm, the authors noted that heart failure hospitalizations and mortality were reduced when NT-proBNPs fell by as little as 10%, regardless of the treatment group. So data on hospitalization and mortality in BDHF obviously is coming, and we await those results. Next slide. And then when we see here, even with ARNI therapy, you can appreciate both arms of BDHF were required to be on max dose GDMT. Baseline treatment with Entresto was similar in both groups, so remember the timing of this study. But patients randomized to the control arm had Entresto added 4 times more frequently than patients treated with Barostim and GDMT. So obviously we would expect more response in that group that's having a higher exposure to Entresto. Despite these changes, the Barostim patients had a 25% relative reduction in their NT-proBNPs compared to control, and they improved their 6-minute walk, their heart failure scores, their Minnesota Living with Heart Failure scores compared to controls. Next. And then obviously safety is paramount to all of us as providers and has to be a given if we're going to offer these therapies to our patients. And this is important that freedom from major neurological and cardiovascular event free was 97%, demonstrating the underlying safety of this therapy. The safety profile is very similar to what you would see in a single chamber ICD or pacemaker study, which I think is very reassuring since we're very familiar with those things in practice. Next. Cardiovascular serious events. So back to our BDHF results. these are some interesting observations. Remembering these aren't powered endpoints, right? But patients receiving Barostim on top of their GDMT were found to have a reduced rate of cardiovascular serious adverse events, so non-heart failure related events or non-cardiovascular death, by 51% compared to patients on GDMT alone, which is pretty remarkable. Of special interest was a reduction in cardiac arrhythmias, which I think all of us are interested in exploring those data more. And this is an area that I think we will look at in future studies. Next. Interestingly, when we're talking about modulation, question has to be raised about impacts on blood pressure, right? And blood pressure and vascular tone. And so this is a common question is, will this make my heart failure patient more hypotensive? Remember that the baroreflex regulates blood pressure, and in BHF, baroreflex activation therapy with the Barostim device was shown to actually have a stabilizing effect and sometimes even a slight increase in the patient's blood pressure over time, as you can appreciate here on this slide. Pretty remarkable data. And at the time of implant, a small acute drop may be noted in blood pressure, but this typically returns to some sort of a baseline in 2 to 3 minutes. And after that, there really hasn't been any documented chronic lowering of blood pressure. And obviously that's important for us when we're talking about GDMT and the backdrop of these therapies. Next. So coming back to this overarching slide, we're really filling in our columns, and Dr. Panjarath did a great job under the heart failure, and now we're looking at Barostim specifically. And we have arrows going in a favorable direction, right? So if we summarize all of this, stimulation of the baroreflex has been shown to increase baroreflex regulation. It does decrease sympathetic tone. It improves a number of physiologic effects that have been documented in either preclinical settings or in small preclinical work or in early clinical work. But more importantly, probably, is that our randomized data in BHF, Barostim therapy was shown to reduce NT-proBNP, improve quality of life, decrease heart failure symptoms, and improve exercise capacity in heart failure patients compared to those patients that were just receiving GDMT alone. Next. So as we started this portion of the discussion, the question was asked, right? Could electrical stimulation of carotid baroreceptors upregulate the baroreflex, perhaps rebalance the nervous system and improve heart failure symptoms? And I think our data demonstrate that stimulation of the baroreflex is an attractive target to reduce heart failure symptoms, as you can appreciate on this slide. We are seeing regulation, we're seeing changes, favorable changes in sympathetic outflow, favorable changes in parasympathetic outflow, and favorable changes in heart failure symptoms. Next. So to build on Grusher's initial summary is, we do know all of this background data. We know how difficult heart failure is to treat. We know we have patients with GDMT that still aren't really getting to where we would like to get them ultimately. And so now we know direct electrical stimulation of the carotid baroreceptors upregulates the baroreflex, rebalances the autonomic nervous system, and improves heart failure symptoms. And we've shown all of these different phases, whether it's 6-minute walk, whether it's quality of life, New York Heart Association, NT-proBNP, all of these are moving in the desired direction.